friends, I'm Dr. Son Young-hee of Egood Dental Clinic. Today I want to talk about post-operative delayed complications after implant placement. I want to address different complications that arise long-term. These basically are the post-operative delayed complications we can face. Peri-implant mucositis, hyperplastic gingivitis, maxillary sinusitis, implant periapical lesion, exposure of implant metal in the upper anterior area, and exposure of superior part of the implant after secondary surgery, chronic pain. There can also be sensitivity and spinning sensation. Also, after implant placement, there can be bone necrosis. First, let's look at peri-implant mucositis. After implant placement, for multiple reasons, there can be inflammation in gingiva or supporting structure. This is referred to as peri-implant mucositis. In other words, there is inflammation in the mucosa around the implant. Peri-implant mucositis also equals ailing implant. The biggest difference with peri-implantitis is that it's reversible. With appropriate treatment, we'll be able to remove the inflammation, and then there will be no issues with supporting structures. Mucositis refers to a situation where it does not accompany bone loss. If there's bone loss, then we refer to it as peri-implantitis. In this case, then we would consider this implant almost failing or near failing. In general, peri-implant mucositis do not accompany bone loss. Let's do one-on-one comparison with peri-implant mucositis and peri-implantitis. Peri-implant mucositis can be considered as gingivitis and peri-implantitis as a periodontitis when we're using natural tooth analogy. There's bone loss here and none here. Implant pathology. Many things can be discussed. We need to look at these three in general. First, also it's similar to progression of periodontitis. After implant placement, on the implant surface, plaque accumulation occurs, and this leads to soft tissue inflammation, and as a result, there will be bone loss. Many people have said many things, but the conclusion is this. Essentially, the problems lead to supporting tissue loss. In the case of peri-implant mucositis, this is limited to gingival inflammation. When we talk about peri-implantitis or peri-implant mucositis, there are many standards used for diagnosis, and treatment scope is determined. What is most frequently used is cyst, cumulative interceptive supportive therapy. The key parameters include the presence of plaque, the bleeding tendency of the peri-implanted tissues, this is referred to as BOP separation, and the presence of peri-implant pockets as well as radiological evidence of bone loss. In the peri-implant tissue, we need to check whether there is bleeding tendency or if there is bone loss. These are considered major parameters. Depending on different steps, pocket depth, BOP, whether it's positive or negative, depending on it, treatment is determined. Different protocols can be used. Mechanical dryman, whether you're going to use it, whether we're going to add antiseptic cleansing. The characteristic of this treatment is that if the pocket depth is between 4 to 5 millimeters, In addition to mechanical debridement, you can add antiseptic cleansing, A plus B. So if additional treatment is needed, you can add C. So it gradually increases if the pocket depth exceeds 5 millimeters, and if BLP is positive, if there is less than 2 millimeters of 2 millimeters, so you can do systemic or local antibiotic therapy. If it exceeds 5 millimeters of pocket depth, and if there's more than 2 millimeters of bone loss, resective or regenerative surgery may be needed. This is an additive protocol. We use these standards when we try to solve problems around the implant. What else is there? This is a decision tree. This is decision tree for peri-implant disease management. This uses mobility as standard. Whether there is mobility or not is a standard. And if there's no mobility, you also need to check whether there's any bone loss. This is referred to as PIMI. In this case, it looks at BOP and existence of bone loss, inflammation, and mobility. There are these methods too. I wanted to show you that there were other standards used as well. In general, we use ASSIST to treat patients. This is hyperplastic gingivitis. Around prosthesis, gingiva continues to grow. If you do mechanical cleansing, and most of the time you can get good results. This is pre-op and post-op. With mechanical cleansing, if you do not do it, the plaque can accumulate on top and hyperplastic gingivitis can occur. Next is maxillary sinusitis. After implant placement, on the CT, the sinus looks very full. We face these kind of situations at times. Sinusitis can occur. There are many reasons for sinusitis. In the case of this patient, there is sinusitis. If you take a look, there is internal infection of graft material, and this will be addressed in detail in offline course. The symptoms of sinusitis, there can be pressure, pain, swelling, and headache. There can be nasal blockage due to mucosal lining. This occurs mostly 3 to 4 days post-op. In order to address it, we can prescribe antibiotics. In most cases, you prescribe amoxicillin. Actually, augmentin would be a better term. You prescribe amoxicillin 250 milligrams and clavulanic acid 120 milligrams. Or you can prescribe 500 milligrams of amoxicillin and 125 milligrams of clavulanic acid. You can prescribe it 3 times a day and have the patient take it for about a week. If the patient does not show response within a week, you can do sinus aspiration, but this is for when there's suppuration. You know when there's signs of suppuration. If the symptoms do not improve, then you would have to remove implant or all of graft material. Next is bone loss. You'll be able to know of bone loss with X-ray. The symptoms may be asymptomatic. At times, the patient can complain of odor, bleeding, or other things. In that case, we can provide this kind of treatment if there is less than 2 millimeters of bone loss. This is pursuant to CIST. If you look at CIST protocol, this is what is articulated. We use an internal submerged type implant. All implant components need to be within bone. That is the principle. If there is a vertical bone loss, then the implant may face potential problems in the future, and we will need to keep it in mind as we provide a treatment. In most cases, a surgical treatment may be necessary. That'll be the result. Yes, responding to the problem itself is important, but placing the implant in a way to avoid these problems is even more important. This is a case where implant metal is exposed in upper anterior, and it shows this kind of tendency. Not just implant color, but implant itself is exposed. So you can see that the gingival biotype is very thin. You can refer to this as a thin phenotype as well, and in such cases this problem can occur more easily. This can occur when the implant is placed too shallow as well. Because of bone remodeling, the labial alveolar bone may be resorbed. If there is a post-op inflammation, this kind of problems can occur. This is impossible to treat. You would have to remove the implant or do different procedures to increase the soft tissue amount here. But in order to do that, at times you may need to remove the implant. In that sense, it can be a disastrous problem. In terms of treatment, you can consider coronally repositioned flap, connective tissue graft, semi-lunar flap, and others. For single tooth case, or if the extent of the problem is small, it can be solved, but basically if the implant metal is exposed labially, then it means that soft and hard tissue support has failed, and I do not think that it will have good prognosis. Next, I'm going to talk about bronze and emrons, which is something that we definitely don't want to come across. This is bone necrosis related to bisphosphonate, anti-angiogenic drugs, and so forth. In the case of bronze, it's related to bisphosphonate. It is an abbreviation of bisphosphonate-related osteonecrosis. When we talk about bone turnover, in order for this to occur, there needs to be osteoclastic activity followed by osteoblast. However, if bisphosphonate is used, osteoclast activation is blocked, therefore there's no bone remodeling or regeneration. There's no osteoclast, hence there's no osteoblast. This is a problem associated with this. I want to talk about bronze and dental implants. When implant is placed or when extraction is performed, if there's a higher possibility of bronze from occurring, if you look at literature, even if implant has been placed and osseointegration is complete, there is still bone turnover. So these implants are not free from bronze-related complications. Let's look at bisphosphonate. This is actually not important. When you look at bisphosphonate, what should be considered important is here. What is most frequently used? Metidronate, alendronate, Posamix. This is used very frequently. Bonviva, and so forth. I want to talk about the two larger factors in determining whether this drug is risky or not. Whether it is injection or oral drug, injection is much more risky. In the case of these drugs, does it include nitrogen? The question evolves around whether it includes nitrogen. At times it does, and other times it doesn't. If it includes nitrogen, it can be more risky. This is the easiest way to determine. In terms of bronze etiology, if it is administered long-term, there's higher possibility of bronze. It's obvious. The injection is more risky, and compared with oral administration, the injection has higher possibility of bronze. Although the probability of bronze in the case of oral administration is quite low, if the patient takes it for over 3 years, then the possibility can increase. Actually, the 3-year part has changed. What is important is here. When the patient also takes a steroid, the probability of bronze increases exponentially. In oral administration, the probability of bronze can also increase in this instance. In 2003, Marx first reported of bronze, and bronze definition needs to satisfy the three. There needs to be bone exposure, and despite treatment, such exposure continues for over 8 weeks. The patient is currently administering bisphosphonate or has history of it, and there's no X-ray therapy on the bone exposure. These three categories need to be satisfied. The stronger the medicine, if you administer it for a longer period, there's higher possibility. The question revolves around whether it includes nitrogen. If you look at localized factors, extraction, ill-fitting denture, anatomical factors, and bronze tends to be more probable in the case of upper. In the case where the mucosa is thinner, lack of oral hygiene, drinking, and smoking. As for systemic factors, there are many, but please remember steroid. There is a position paper. Continuous revision has been made. First was reported in Korea. Stage can be divided from 0 to 3. As you progress to stage 3, the symptoms worsen. Stage 0 and stage 1, there are different treatment modalities for it. In most cases, we come across cases where the patient has stage 2 or stage 3. And in most cases, you prescribe antibiotics. You may do envelope resection or curettage. Surgical management is also accompanied. And in 2014, bronze-related information was updated and MRONS was introduced. What is different? This is related to medication. Not just bisphosphonate, but other drugs also cause this. Anti-resorptive medication, anti-angiogenic medication, these can cause the similar symptoms. And these drugs are mostly used for anti-cancer therapies. Bronze was revised to MRONS. There are different medications listed here. Most of them are denosumab drugs. When treating osteoporosis, denosumab is used frequently. So, case definition is as shown. MRONS, denosumab, and other drugs have been added. The result is the same and symptoms are the same. These drugs also deduce similar results. So if you look at the prevalence, it is about 0 to 0.04%. In the case of Korea, the possibility of bronze is 1 out of 2,300, 0.04%, and it occurs in patients over 70. The variation range from 38 to 88, and 22% is related to bisphosphonate. About 2 out of 100,000 people suffer this because of oral bisphosphonate, 90 out of 10,000 due to IV bisphosphonate, so this is fairly high. Oral bisphosphonate is considered safer. If you look at pathophysiology, they both suppress bone turnover. They inhibit osteoclastic activities and these symptoms result, and they're the same. Systemic factor and local factors is the same. Systemic factors include the use of steroids. The problem tends to worsen. This is the common ground, and if you look over here, suppress the bone turnover markers. Bone turnover rate, whether you know how suppressed it is not an absolute criteria, but you can use serum CTX. CTX level, this is not an absolute figure and you cannot just overly rely on it, but actually, realistically speaking, this is the only telling thing. The normal figure you should take note of. Patients who do not take bisphosphonate show on average 300 picogram per milliliter, and in general it will be around 400 to 550. What happens if the patient who used to take bisphosphonate quits it? The level goes up by 25 every month. Then when should you not perform extraction or implant placement? In the case of high risk, it is under 100, minimal risk is 150, and moderate risk is 100 to 150. If it is over 300, then you can assume that there will be no problems. This is not an absolute figure, and this is the only thing we can utilize. The CTX test should be performed when the patient has empty stomach, and this is normally done by a different division. CTX is an abbreviation of C-terminal cross-linking telepeptide test. This refers to the very end, C-terminal ending of type 1 collagen. How much of it is included within the blood is reviewed. Activation of type 1 collagen is reviewed, and this is very related to the bone turnover. Type 1 collagen activation is keenly interrelated. Perhaps we can do drug holiday. It may be necessary, but there are different guidelines. For patients who have taken bisphosphonate within 2 years, according to ADA guideline, you can just perform treatment. However, AAOMS says that you need to have at least 2 months of drug holiday. And in the case of CALMI, you need to have at least 2 to 4 months of drug holiday. This is the recommendation. This is not a principle, but a recommendation. According to FDA, it says there's lack of evidence as to whether there needs to be drug holiday. There's no consensus as of yet. I am sorry to say this, but when you ask me whether or not to place implant in a patient who has been taking bisphosphonate or anti-resorptive drugs, it's difficult to answer that question. No one can actually answer that question. However, if there is MRONs, then there needs to be drug holiday. This is for certain. Up until now, I've talked about the delayed complications we can face after placing implant. There's much more to say, and I've abbreviated as simple as possible. If you're interested in more specifics, please refer to offline master course and let's study together. Thank you for watching.